Derm other associated blistering skin disorders. Okay, so we talked about the autoimmune blistering skin disorders. These are the other ones. First, we have dermatitis herpetiformis. Dermatitis herpetiformis is going to be an association with celiac disease. It's going to be very pruritic papules, vesicles, and bulla. Okay, they're often found on the elbows, the knees, the buttocks. Okay, and once again, highly associated with celiac disease. And what's going to happen is deposition of IgA at the tips of the dermal papilla, okay? So that's kind of what they want you to know. Next is erythema multiforme. Erythema multiforme is associated with infections like Mycoplasma pneumoniae and HSV, okay? Those are two high-yield associations that you should know. What's going to happen is it's going to start on the back of the hands and feet, and then days to weeks after an HSV outbreak is when you're going to see erythema multiforme. So if it's something that starts on the back of the hands and feet, then you know you should start thinking about erythema multiforme, right? Now, you're going to see multiple types of lesions. One main lesion is going to be target lesions. So it looks like targets with multiple rings surrounding it and with a dusky center in the middle. And that is what erythema multiforme is kind of known for, is those target lesions. And take a look at it on one of the photos in your books, okay? Next is going to be Stevens-Johnson syndrome. Okay, Stevens-Johnson syndrome is going to be the loss of the epidermis, and this is going to be starting on the face and chest. So erythema multiforme is starting on the back of the hands and feet. Stevens-Johnson syndrome is going to start on the face and the chest, and it's going to be due to loss of the epidermis. Now, this is very, very scary. What's going to happen is the patient's going to present with a fever. They're going to have bulla formation and necrosis, sloughing of the skin at the epidermal junction, and it's essentially going to be starting on the face and the chest. It has Nikolsky sign positivity, and it carries a high mortality risk. Now, what happens here is that the mucous membranes are usually involved. So the patients you're usually going to see, like, once again, when it starts on the face, it could involve the mouth mainly. The mouth mainly can be affected, and that can give you a hint for Stevens-Johnson syndrome, okay? Now, they may appear similar to erythema multiforme, but remember where erythema multiforme starts, it starts on the back of the hands and feet, whereas Stevens-Johnson syndrome starts on the face and chest with mucus involvement, okay, mucous membrane involvement. Now, it usually is associated with an adverse drug reaction. One of the main ones is lamotrigine, right? We talked about in neurology, the anti-seizure medications usually cause SJS, but there's also multiple other medications that can cause it. And what we're worried about is toxic epidermal necrolysis, which is TEN. TEN is essentially the same thing as SJS, but it involves greater than 30% of the body surface. And so then this is where we get severely, severely scared, okay? Take a look at what that looks like. Look up both SJS and TEN and memorize those photos because that's how they normally like to present it as. Next, I'm going to be discussing cutaneous ulcers. Cutaneous ulcers, there's different types: venous ulcer, arterial ulcer, neuropathic ulcer, and pressure injury ulcer. So pressure injury is the easiest one. If you see a patient that has been in the hospital for days on end or weeks on end or months on end, or they're paralyzed, they can't get out of bed, like anything that leads to decrease in ability to move can increase your risk of pressure ulcer, okay? And these are also known as decubitus ulcers, okay? It just is based off of the position that the patient's in. If they're in prolonged, unrelieved pressure, immobility is the highest risk factor, okay? And it's usually going to be seen on the weight-bearing points, so specifically like the sacrum, the butt, where a lot of the weight is being pushed on, okay? Very, very high yield. It's going to be painful, and you could see a complication of like soft tissue infections and osteomyelitis. Next, and probably the most important one out of these, is going to be the venous ulcer. You have to take a look at what venous ulcers specifically look like. It usually is going to be secondary to venous stasis, okay? And that venous stasis is usually due to incompetent venous valves and venous dilation, like varicose veins. And so when you have all of that venous stasis occurring, it's going to pool at the bottom, whether it might be due to the venous valve issue or venous dilation, like the varicose veins. They're going to just stay there, and that blood's going to stay there chronically, and it's going to cause, or it's going to, because of the chronic venous insufficiency, it could lead to a venous ulcer formation on the skin. Okay, what they want you to know specifically is that it's going to be seen mainly on the ankle or mid-calf, typically over the malleoli, and the appearance is usually going to be like irregular border with shallow exudative stuff, okay? Now, the arterial and neuropathic, once again, not too high yield. If you see some of these, neuropathic is usually going to be due secondary to diabetic foot infection because of peripheral neuropathy. That's probably the highest yield thing that you should know from that. But once again, cutaneous ulcers, very, very low yield. Don't think too much about them. Diabetic foot infection that leads to neuropathic ulcer is probably the highest yield of them all. Next is going to be miscellaneous skin disorders, so stuff that doesn't really fit in anywhere else. First, we have acanthosis nigricans. Acanthosis nigricans is going to be epidural hyperplasia causing symmetric hyperpigmented skin, thickening of the skin. Okay, and it's usually seen in the axilla or the neck areas where you have kind of like skin overlapping. And it's highly associated with insulin resistance. So patients with diabetes or obesity have an increased risk of acanthosis nigricans. That's what they'll see. You can also see it in PCOS. And it has a high association also with some type of malignancy, specifically gastric adenocarcinoma. Remember, acanthosis nigricans, as well as what other sign can tell you that it could be a gastric adenocarcinoma? Lesser Trellat sign, okay, right? The lesser Trellat sign. And we could go back to it. It's caused by the multiple seborrheic keratoses, right? Multiple seborrheic keratoses that is rapidly onset can also be a sign of gastric adenocarcinoma. Same as acanthosis nigricans, which is just that epidermal hyperplasia that causes hyperpigmentation, thickening of the skin, usually in the axilla or the neck. And remember its association also with insulin resistance. It's very high yield. Next is going to be erythema nodosum. Erythema nodosum is it's like a painful, raised inflammatory lesions of the subcutaneous fat. So they want you to know it's like between fat cells is what is inflamed. So it's like septal paniculitis is what they call it. And it's on the anterior shins. So erythema nodosum is on the anterior shins. Honestly, the associations are sarcoidosis and anything that's like a fungal infection. Okay, those are the high yield association. But erythema nodosum is lower yield. Next is ichthyosis vulgaris. Ichthyosis vulgaris is going to be defective keratinocyte desquamation due to a filaggrin gene mutation. Filaggrin gene mutation. So it's defective keratinocyte desquamation with scaly skin due to filaggrin gene mutation. It has a very strong association with, can you guess? Atopic dermatitis. The reason I wanted you to guess that is because if we were to take a look back at atopic dermatitis, we also know that it's associated with a filaggrin gene mutation. So the two filaggrin gene mutations are atopic dermatitis and are ichthyosis vulgaris. And it just so happens that they're associated with one another because of the filaggrin gene mutation. Ichthyosis vulgaris, they want you to see what a photo looks like. Make sure you see what the photo looks like. It looks like severely dry skin. Okay? And it's defective keratinocyte desquamation with scaly skin. That's what they want you to know. Next is lichen planus. Lichen planus, what you want to know is that it's itchy, purple, flat lesions. Okay? So lichen planus has a sawtooth and hypergranulomatosis. So it has sawtooth infiltrate of lymphocytes at the dermal epidermal junction, and it has hypergranulosis. Okay, so this is the only one that has hypergranulosis, which is increase in the stratum granulosum. Okay, so if you see increase in stratum granulosum, you should start thinking of lichen planus. It will have band-like lymphocytic infiltrate, right? Sawtooth infiltrate, as well as band-like lymphocytic infiltrate. And you will also see hyperkeratosis present here as well. Okay, they want you to know this. It has a high yield association with hep C as well. So lichen planus, what would I see? Itchy, purple, flat lesions should be your first thing that you see. You will see hypergranulosis and hyperkeratosis. You will have sawtooth and band-like lymphocytic infiltrate, and it will be associated with hep C. That's lichen planus. Next is pityriasis rosea, which is going to be very itchy. It will present with a herald patch, followed days later by a scaly erythematous plaque that looks like a Christmas tree. It's going to be Christmas tree distribution on the trunk. What they love about it is the herald patch. Okay, herald patch is very, very high yield. Lastly, it's self-resolving within 6 to 8 weeks. Make sure you know what the herald patch looks like. They like to show it a lot. The Christmas tree distribution, not too much they will show it, but it still is associated, okay? And lastly is sunburn. Sunburn is just going to be burn due to excessive UV irradiation, okay? So excessive UV exposure, it's going to cause DNA mutations and leading to apoptosis of keratinocytes. UVB is going to cause sunburn. UVA is for tanning and photoaging. Okay. Now, both UVA and UVB lead to an increased risk of skin cancer. So what they want you to know is that photoaging is due to UVA exposure, which leads to decreased collagen fibril production and overall increase in degradation of collagen and elastin in the dermis. So that's what causes the photoaging type of stuff. And that's why UVA causes photoaging, is because decreased collagen and fibril production and an increase in degradation of collagen and elastin in the dermis. All right. So overall, that's what you need to know. Once again, cutaneous ulcers, honestly, don't even worry anything about it. That's what I would say. For the other blistering skin disorders, dermatitis herpetiformis is easily associated with celiac, erythema multiforme associated with HSV and mycoplasma pneumonia, starting on the back of the hands and the feet, and it's going to be usually days to weeks after an HSV outbreak, and it's going to have target lesions. Stevens-Johnson syndrome, SJS, caused by any type of like drug that has SJS as a side effect. You see loss of epidermis, and it starts on the face with mucosal membrane involvement, and it could start on the chest as well. We're worried about TEN, which is just going to be essentially SJS with greater than 30% of the body surface involved. Acanthosis nigricans is epidural hyperplasia with hyperpigmentation and thickened skin associated with insulin resistance, like diabetes, and gastric adenocarcinoma, usually seen in the axilla or the neck. Erythema nodosum, not too high yield. Nothing really you need to know about it except for its association with sarcoidosis and with fungal infections. Ichthyosis vulgaris is going to be strongly associated with atopic dermatitis because of its filaggrin gene mutation, and it's going to cause defective keratinocyte desquamation with scaly skin. Make sure you know what it looks like on imaging, just like on physical exam, like what it actually looks like on the skin. Lichen planus is an itchy purple flat lesion. These are the P's: pruritic, purple, polygonal planar, papules, and plaques. Okay, but what I care about is that it's itchy, pruritic, and it's purple, and it will have hypergranulosis along with hyperkeratosis, and you will see a sawtooth and band-like lymphocytic infiltrate associated with Hep C. Pityriasis rosacea is going to be herald patch, okay, with a very itchy Christmas tree distribution trunk later on. And lastly, sunburn is going to be UVB for burn. It's going to be apoptosis of the keratinocytes because of DNA mutations. And then UVA is going to be tanning and photoaging due to decreased collagen fiber production and increase in degradation of the collagen and elastin in the dermis. All right, that is all. And lastly, we're going to be discussing skin cancer.